Good morning. Thanks to Dr. Kapil Gupta and Mr. Henry that they have made my job this morning very simple in that I do not have to justify why we need this kind of approach to see whether asymptomatic carotid disease does need any treatment or not. The hallmark or the problem that we have is the carotid plaque. The carotid plaque become vulnerable because of some local changes as well as influenced by some systemic problems that occurs at the same time. Now, it is therefore very important that we identify what are those changes which takes place in the carotid plaque that makes a plaque vulnerable. In other words, that these plaques could rupture, could embolize, and could cause a stroke. The so-called salient features of a vulnerable carotid plaque that has been shown in various studies, first of all, is the lipid core, then the fibrous cap, and on top of that, the inflammation and angiogenesis that takes place on those carotid plaques. Now, we need to identify these things by some means or other so that we can label that particular carotid plaque is vulnerable, even if the patient is asymptomatic, and we can plan the treatment at an appropriate time suitable to both of us. Now, as I said, that Dr. Gupta has already given a very nice illustration of the natural history of carotid artery disease, but I'll give you some idea about what happens in the asymptomatic carotid disease. And as you have already heard also, what is the risk of stroke in patients with severe carotid stenosis, and also what impact it will have on the health economy of the world, and particularly in UK, in India, or for that matter in USA, if we have to operate upon every patient with asymptomatic carotid disease, and how is it going to have an impact on the management of the stroke victims who did suffer from stroke in the rehabilitation program. So coming back to the first thing, which is the natural history of carotid disease, and these data that I have presented to you are something which were done before we introduced the lifestyle management concept or the best medical treatment, which includes the stopping smoking, exercise, antiplatelets, antilipids, and so on and so forth. What it shows that although the majority of the patients who have asymptomatic carotid disease, over 50% stenosis, that they have a risk of stroke, but not sufficient to justify a treatment. And also there are many patients who have got disease over a 5-year period. The carotid artery may occlude, but without having a stroke. And if you look at the ECST study data, and which Dr. Gupta alluded also to, that following a first attack of TIA, if the patient did not have an operation, what happens over a period of 3 years? The risk of stroke in these patients normalizes to that of a patient without carotid disease, which is that graph falls from a highest risk of stroke to almost 4% at the end of the 3 years. In other words, this happens largely because the plaque has an opportunity to become stabilized and the risk of embolization becomes much less. So therefore, there is no need in these patients to intervene if the risk is the same as a general population. There are 4 landmark clinical trials that have been performed in North America and in Europe, and all of them quite convincingly have convinced us that carotid endarterectomy is the choice of treatment, both in symptomatic as well as asymptomatic patients. But one important thing, measurement or indicator that we need to look at quite carefully is in the asymptomatic group, if you see that we need to operate upon 30 patients, 30 asymptomatic carotid stenosis patients in order to prevent 1 stroke. Whereas in symptomatic group, you need to operate upon 6 or 9 patients in order to prevent stroke. What it means that we will be operating on 29 patients with asymptomatic carotid disease unnecessarily or may not be needed in order to prevent 1 stroke. And those 29 patients may suffer from the complications of surgery or other things that could happen due to concurrent medical illness. And as we have already seen, that the risk of cranial nerve injury, particularly the recurrent laryngeal nerve, is very common to the extent of about 8% following carotid surgery. And if somebody's got a hostile neck, previous radiotherapy or previous surgery on the neck, and if they have also a recurrent laryngeal nerve palsy due to carotid surgery in the other side, then in an asymptomatic patient, the risk of having any further problem also increases. And similarly, there are other complications that may arise due to carotid intervention. Therefore, does it justify in operating upon these asymptomatic patients with this kind of complications that may happen? So in other words, what we need to do, we need to identify which are the group of patients with asymptomatic carotid disease who have a vulnerable plaque, who may benefit from surgery or any intervention, whether stenting or surgery. Now, in UK, the principle of care is that if you need a cardiac transplantation or if you need a removal of sebaceous cyst, it will be done free of charge. The UK spends about 9% of the GDP, which is about $150 billion in health services. Similarly, in the United States, about $2.3 trillion, which is about 14% of the GDP, is spent in the health services, and it is also increasing to about 16 to 17%. And what I understand in India, the amount of money that is spent in health service by the government is about $37.3 billion. The amount of resources that we have is not unlimited. So therefore, we have to identify how we can assess the need of the patient and benefit them by whatever intervention we do. And as I said, that stroke rehabilitation itself causes quite a significant proportion of the health budget in the United Kingdom. And that justifies that we should target those vulnerable patients. So therefore, there is a need. And what are those needs? What are those things that we can do? Then we can correctly or accurately identify those patients. So now I'm going to discuss you some of the methods that has been already established, but they are still not the gold standard, but they can be validated, and hopefully in future, we will find a way to screen those patients and benefit them by appropriate intervention. But in order to justify what technique you want to do, we need a simple technique that should be non-invasive, can be easily done, reliable, and available cheaply, and this is an ideal method for screening. There are a host of various methods that can be done in order to do that, to identify the vulnerable plaque. The two topmost are probably the best way of screening methods to identify the vulnerable plaque. But there are also other ways, MRI scanning using iron oxide or CT PET scanning, which can also demonstrate a plaque is vulnerable or not by looking at the inflammation or angiogenesis. And also we can do by other ways to find out from the MRI study whether plaque is vulnerable or not by doing MRI study. And also, I think circle of Willis is a very important structure that we also should look at if we want to assess whether somebody is at risk of stroke or not. I will also describe, these are the two methods, which is the intraplaque temperature measurement or intraplaque pressure measurement, but these are mostly research tools which can be used to validate any method that we do to justify that this is a vulnerable plaque. So I will describe each of them one after another. There is a very nice study that was the ICAR study that was done to look at the plaque characteristics, looking at the ultrasound pictures, by defining them whether it is an eco-dense plaque or whether it is an eco-lucent plaque. And what is called the grayscale median score that was derived from this characteristic of the plaque. And if the plaque is less than 25, which is more of the eco-lucent, the risk of stroke is about 7.1%. Whereas if it is eco-dense, then the risk of stroke is 1.5%. Therefore, it makes all the more reason that probably we can depend upon the ultrasound scan to identify which plaque is more vulnerable. This is a CT PET scan which shows that there is an area of inflammation that corresponds to the histology quite clearly, And this can also identify a vulnerable plaque. But the CT PET scan is not available in every hospital, and secondly, it is very expensive. And thirdly, it involves radiation, and therefore it can't be used as a screening tool. I think one of my slides is missing. I hope they'll get it. So what is a vulnerable plaque? In this, what I have shown, the most important area is the fibrous cap, and it has got black solder, the fibrous cap, and that is the lipid core, and that is the lumen. And each plaque has got the collagen distribution, some of them loosely, some of them tightly, some of them are broken, and that also affects the vulnerability of the plaque because the solder can disrupt and cause vulnerability to embolization. What we did, we looked at the thinness of the fibrous cap, we looked at the collagen content of the fibrous cap, and also looked at the lipid content of the fibrous plaque in order to justify whether the fibrous cap is vulnerable or not. Now, this is the test that we did was looking at, first of all, the cap thickness. We found out that if you compare between the non-ruptured and ruptured plaque, the fibrous cap thickness is higher in the non-ruptured plaque compared to the thinness of the fibrous cap. Although our test did not reach statistical significance, but it did show a trend that this could be one of the components of a vulnerable plaque. Secondly, we also looked at the amount of collagen distribution in the fibrous cap. Again, we found that there is significant difference between the non-ruptured and ruptured plaque, although they did not reach statistical significance, but they were important. And thirdly, then we looked at the lipid distribution in the non-ruptured plaque compared to the ruptured plaque. There was a significant difference between the lipid distribution, and that also stood statistical test of significance. Then we looked at whether we can measure the stress level in the wall of the carotid artery, and that can determine whether the plaque is under stress or not. But we looked at what is called PFS, past primary stress at the carotid artery at the ruptured site, and using the computational flow dynamic study, we developed the model, and we prepared different thickness of the fibrous plaque, and then we found out in 3 TIA subjects how the stress distribution is there at the rupture site compared to the non-rupture site. And we found out at the rupture site, there is always a high pressure or high stress that is being transmitted, and that probably is responsible for the rupture of this carotid plaque. And that's again shown in these 3 patients with TIA. By changing the thickness of the fibrous plaque, we showed that the maximum stress distribution is at the site of the rupture. And this is, sorry. This is looking at the circle of Willis, again using computational flow dynamic study. We looked at the regional distribution of blood flow in the presence of carotid stenosis, and we found out with the lack of posterior communicating artery or intercommunicating artery, the regional distribution suffers quite tremendously in the presence of severe carotid stenosis. Therefore, we think that study of the circle of Willis can also identify which patients are at risk of stroke. Sorry. I just want to show you one more slide, which is the most important slide. Now, this is another very interesting thing which is developing, that what is called ultrasound microbubble, like in MRI iron oxide microbubble, in ultrasound scan, using the contrast media injection, you can see the deposition of the microbubble in the carotid plaque because it is ingested by the macrophage, which can't be shown in standard ultrasound scan. And this is probably the future, together with the GSM scoring and the deposition of microbubble, may identify those vulnerable plaque who are at risk of rupture. So I'm very grateful to all these co-colleagues who have contributed to all this research that we have done over the years. And hopefully, someday, we will be able to validate this method the GSM scoring with that of the microbubble with other traditional method and identify vulnerable plaque much more accurately. Thank you.
That was really an excellent presentation. Very good work and very impressive. People need to really look at that.
Thank you.
Just want something more about the contrast bubble, vulnerable plaque. Something more in detail about how to use the contrast. We do a lot of contrast for the cardiac, and how to do it in the ultrasound for the carotids.
We do the late phase scanning. This is when the macrophages ingest the microbubble.
No, it is same contrast you use and what Sonoview. And when you use the, will it be done with Definity?
Yes.
Same. Yeah. And the NACRE setting and the MI setting will be the same as that for cardiac?
We use the linear probe.
Linear probe, fine. And the MI will be, the myocardial index will be again 0.25, 0.2.
I'm sorry, I didn't get it.
The ultrasound settings
yes.
with the index will be low as we do it in cardiac.
I'm not conversed with the cardiac.
Is there a special setting for the carotid?
Settings are different from the cardiac settings.
The cardiac settings are different. And
our probes are 7.5 megahertz.
oh, that's okay. Probe is fine, but the machine will be the same. And the setting should be the same.
Vascular setting.
Vascular setting. And when you do that, what exactly you see? The late phase. What do you mean by the late phase?
I mean, as I showed you, the microbubble has been ingested by the microphage, and which starts a shadow, the color set that you saw in the scan. And that is what is important, that to say that this plaque is vulnerable.
So whenever a plaque takes away the microbubble, it means it is vulnerable.
I show you the comparative slide, which shows that the standard slide, which does not have any ultrasound microbubble, and therefore that justifies it.
And it will take in how many cycles when you inject?
After about 30 minutes, you will see that
30 minutes of 3-0. That means we do the baseline study and we do it again at 30 minutes.
Mr. Chairman, we have run out of time for this particular presentation. With your permission, we move on to the next presenter. That's Dr. O.P. Yadav. And he is here to